This week on the BackTable podcast.
What happens a lot is, especially when you're younger, you're just in the zone of trying to get this hook. And now you're like, got this forceps that it's like going array. Like you're just poking that thing, like it's going forward. You're like, with it open and you don't want it to poke through and get onto the other side like the aorta or something like that. So just being calm, being aware, making sure you're just very controlled technique is really important. So I think that just comes with experience, honestly.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. First, a brief message from our sponsor.
For over 50 years, Argon Medical has been a dedicated partner in providing interventional solutions that empower physicians to deliver exceptional patient outcomes. Argon is a U.S. manufacturer and an innovator that partners with healthcare providers globally to offer vascular and oncology solutions, like the Scorpion Portal Vein Access Series, which utilizes a patented curve-in-curve system to offer physicians 360-degree range of motion for procedure accuracy and versatility. Argon relentlessly pursues better in all that they do, as demonstrated by the recent product launches of the Kodiak Dual-Port Coaxial Introducer Kit and the SuperCore Advantage semi-automatic biopsy instruments. Learn more about these products and Argon Medical's mission to improve the lives of patients and caregivers at argonmedical.com. And now back to the show.
Hello, everyone, and welcome to the BackTable podcast. We've got a great episode today. We're going to be discussing IVC filter retrievals with Dr. Noor Ahmad. Welcome, Noor. Welcome to the show.
Thanks, Aaron. I'm a huge fan. Appreciate it.
Thanks, man.
Thanks.
I actually get to come to Colombia in like a week and a half, less than 2 weeks.
I heard.
Yeah, I'm excited.
I'm excited.
Yeah.
That's why I was like, should we just do it live in person when you come?
I know.
And that's awesome. I'm excited about that.
To the listeners, I want you to check out prior episodes covering filter tracking. Episode 339 we did with Bob Ryu, Warren Clements, and Pramil Trivedi, as well as episode 204 with Stephen Wang, who was at Kaiser, talked about building a filter tracking program. But in the 450 episodes we've done, we've never actually done one just covering filter retrievals. We did put out the live case that Sinai did on YouTube, so you guys can catch that as well. But I'd love to, what I'm excited about is, picking Noor's brain about how his algorithm for filter retrieval from, how do you get these coming in to, are you doing lasers? Are you doing everything, everything under the sun? Like, what do you have available? So we're going to get into all that. But first, Noor, I'd like to start out with an introduction to where you're at and what your practice looks like.
Sure. Thanks, Aaron. I appreciate it. So I'm about 9-10 years out of practice now. Currently, I'm at Columbia. I've been here since 2020. I came here actually in the middle of COVID, surprisingly. So it's a little bit of transition. But yeah, I've been here for 5 years. The practice has obviously grown. There's about 14 of us in the practice. All of us do everything, which is nice, but we also have our little niches, and mine has been filters, venous work, deep DBT, and complex filter retrieval. So
nice. And so let's jump into the filters. Really, where do your filter placements and retrievals typically come from?
So generally, kind of run-of-the-mill placements, retrievals are, in-house refers, various services. For example, we're a large transplant practice here. When it comes to lung transplant, liver, renal, kidney, again, it's just in-house refers for placements. Even GYN, for example, is a kind of a little niche refer for pre-op filter placement, or for any reason if the patient has previous clot or they have to be off anticoagulation temporarily. And we have a big spine hospital, for example, that do a lot of scoliosis surgeries, and we partner with them. So it's really internal. And then honestly, when it comes to like complex retrievals, I think Columbia, we've gotten our name out there as being a complex retrieval center. And I do get referrals from random places around the country, like Alabama or like, Northeast, or most recently it was like Miami or something. So
wow,
I think people just Google it and and just figure it out, honestly. So
well, that's cool. And so like, how do you guys, so for the run of the mill ones, do you have a tracking program, and was that already in place when you joined the practice in 2020?
That's a great question. When I came in, we didn't have one in place. The first thing I did was I basically did a search of I remember distinctly in my first couple of weeks, because I'm trying to figure out what niche I want to kind of go after. I've always been interested in DVT and PE work on my prior practice. So here, I basically kind of did a search of filters that were placed in the last 3 to 5 years, essentially, by our practice. And through that, we were able to kind of get, no pun intended, filter out patients basically who we can target for getting their filters out, usually younger patients if needed. And then after that, that was around the same time of implementation of Epic as our EMR. So after that, we've created, essentially, it's pretty simple. It's an Epic list where anytime we place a filter, we put a patient on that list, and then our coordinator, we have a patient care coordinator who basically goes through that list and after a certain period of time sets follow-ups and then consults inpatient, like in-house or consults into our clinic. And it could be virtual or in person, depending on where the patient is. So that's been our system, and, we don't have a lot of practices kind of, have a defined filter clinic practice. We have a pretty robust clinical outpatient practice, and it's kind of built into that model where a lot of our patients are just streamlined for consults, depending on who placed those filters. So.
Got it. So you're getting not only the ones that you guys place, which you're tracking, but maybe ones that cardiologists placing, vascular surgery within Columbia.
Yeah. Those, and honestly, we've developed a pretty good relationship. For example, our interventional cardiologist colleagues that when they become, for example, a complex retrieval that they need our expertise, they'll actually refer them over to us, which is nice. So. I think over time we've established, I was pretty aggressive when I came here to kind of get our name out, say we could do laser, we could do forceps, anything, all these techniques. And over time, how it works, you get some good outcomes and you get more patients, and then you just kind of build that relationship. So. And
that's because your former practice before Columbia, you were doing a lot of this stuff and you came in just kind of like wanting to build that.
Yeah. So just background, I trained at Cornell for fellowship, and my mentor there was Dave Trost. And Dave Trost I think he's like a god for filter retrievals, honestly. So I learned everything from him. He was, that's where my interest really developed from it. I would see these crazy retrievals that he would be able to do in a pretty, at relatively ease manner. So I think I just kind of gained an interest from them, carried it over to where I was before. I was at Staten Island before, and it's more of a community hospital, but still you can build relationships directly with referrers, get good cases. And we had a large, actually, PE practice there for thrombectomy. And through that, we kind of developed, just the experience kept building up. So
very cool. And so when you're doing these, and this kind of goes back to the basics a little bit, but when you're doing these like run-of-the-mill pre-op filter placements, do you guys have a set period of time that you let the surgeons know, hey, I got to see this patient back in 3 months, 6 months, what have you?
Yeah, 3 months.
3 months.
Usually it's 3 months, and we've, again, it's a unique niche for. Just give me an example. Our lung transplant program is pretty aggressive about, and I told my trainees this is that if you develop good relationships with the referrers, such as for example this lung transplant program, then you have that trust that we're going to get that follow-up taken care of. If you kind of get these refers that are just like sending it to you and then potentially would forget it, then the onus is on you to really track that patient, right? So certain refers we have that relationship with where we trust that even if it falls through our cracks for some reason, they're going to send it back to us. But then we have that, it's like that backup mechanism with our coordinator just to make sure that a lot of these patients don't fall through the cracks if it's not from our unique refers that we have here. So
yeah. For these complex retrievals, what's your definition of complex, and how do you work these patients up?
That's a great question. So we see anytime these patients come in consult, we see them all in our clinic initially. And honestly, if they're out of state, I'll just see them as a video visit initially just to get an understanding what the history is. Oftentimes you hear things like, I had this filter placed years ago. I don't know when and why. If it's a younger patient, for example, and, then you got to kind of dig through the history, try to figure out what type of filter, why it was placed, what symptoms they had, things like that. And, when I think complex, it's a pretty low threshold of patients that had a filter in for at least like 6 to 9 months. And that when you start getting it from the history that, this filter's probably been in there for years, it's probably scarred in. And then I'll go to the next steps, which is getting like pre-op imaging. And often I'll check, for example, if there's a patient in our system and they had a CT within the last couple of years, I'll get a good idea. And a lot of those patients do have that, like a non-con CT abdomen, where I can get a good idea what type of filter is if it's fractured, if it's tilted, and that all those are signs that it's going to be a complex retrieval. If I have no imaging and they're from outside, what I do is I set a follow-up in-person visit with them, or if they're out of state, I even get them to just get a CT abdomen and pelvis with contrast, and I'll be able to see if, for example, what the orientation is of the filter, if there's any clot, all those things.
What kind of filter, right? Because like a lot of times they don't know.
Most important, yeah, exactly. And I have this cheat sheet I have for the trainees. Like literally, it's just a picture of just all the filters. It took me years, honestly, to actually I think I finally got it. But you get confused between Simon Nightingale and like G2 and all these different brand names. So over time, after doing it this many years, I think I finally got it. But I tell my trainees, keep this up, especially if you're trying to build a practice, just to understand. So yeah, exactly. You get from the imaging, you figure out what type, because that's so important of how you're going to attack, and we'll talk about it, I'm sure. But
yeah,
that's a key piece of information for sure.
That's a great idea. It's like you created a field guide for filters. I was like a big nature nerd when I was growing up, so I loved field guides for birds and reptiles and all that stuff. So I think that's great. You should I don't know if you considered publishing it, but granted, there hasn't been as many new ones, right? There was a while there where there was a new one. It seemed like every couple of years, but I think they've stopped because we know that how dangerous they are.
Yeah, exactly. I think a lot of the filters that I deal with that need to take out the turn into the complex came in that sweet spot period of in like the early 2000s, or that's the sweet spot of where I think there was everyone was putting filters in during that time.
Right. Right. The vendors were making, new types and all this thing, but I mean, it's been years since I've heard of a new type of filter that's come out. I mean, what about you? Do you know anything of any new ones?
No, I think honestly, the companies that reach out to us for assessing and analyzing and getting on trials and things like that are these filters that are that turn into, like, for example, the one that opens up and lines up to a stent after a certain period of time. You don't have to worry about it, right? Or they become degradable, or I think that's what everyone's looking at, is how do we turn that filter into a filter that you don't have to retrieve, and that you don't have to worry about, because they know that need is there potentially of, there's a lot of practices, unfortunately, still that they'll put in filters and obviously forget about them, right? Community hospitals, things like that, even big academic programs, other services, things like that. So I think that's where the focus has been in development, to be honest.
Absolutely, yeah. Anything bioabsorbable would be fantastic. Leave nothing behind, sort of thing. Well, cool. Let's get into, so you kind of talked a little bit about how you prepare for these in terms of imaging. Do you ever do a CT venogram protocol, or do you just stick with a regular CT protocol?
I do. Usually, if I can control it, if they're at our institution, I do a CT venogram where I honestly, I like to have a non-con and contrast. Honestly, that's why, honestly, if a patient had a non-con CT, that's really good enough for me. Because I'll get an idea, and as long as they don't have signs of thrombosis or anything like that, I'll just do the venogram on the table. But if I don't have any imaging and it's fresh start, I'll basically do the CT venogram, non-con, and then a venous phase. Basically.
Yeah, for more information. And so, how do you prepare the patient for this? Because hey, this is going to be a tough one. Do you typically do general anesthesia or moderate sedation, or I guess does it depend on the case?
That's a great question. So preparing the patient is patient selection. Preparing them is so important, honestly, because you get patients that are freaking out. They've been told like they need open surgery to get these filters out. There's no reason why to even worry about it, and now they got symptoms, right? So they're already coming in pretty scared about how to get this out, right? So it's important to get all the information first, what their history is, why it was done, and then really when you're kind of coaching them through the situation of what it's done. And part of patient selection, for example, like I've had patients where their kids bring their 85-year-old moms, and they're like, I read this article, you can take this filter out, and I'm really worried about it. And you kind of have to ease them, being like, and I have a personal story. My mom is older, she's got medical issues, and she's got a filter from 2000, a Greenfield, right? And I don't want to take it out because there's no use in it, right? Because there's more risk than benefit in that situation. I tell patients that all the time. But if it's a younger patient that's active, and that there's that the occlusion risk is high, given you that you compound it over years, those are the patients you really want to select and help out when on these complex filter retrievals. And Then when it comes to saying, hey, we have to do these are your options, and I tell them the options of keeping it in, this is the risk of it occluding. These are patients that don't have symptoms. And I'm gonna let them, I'm happy. I do recommend taking it out given your age and things like that, but I leave it on them. And I tell them, honestly, I'm very open as far as giving them the worst case scenario when it comes to giving general anesthesia, all the techniques that we do, and say we have a really high technical success rate of over 97%, 98%, even higher to take this out. But potentially these things could happen, which even if they do happen, we can control it. So there's a lot of coaching through this situation. So, and back to your question, general anesthesia, for a complex retrieval, I usually go straight to general anesthesia, because if you go to forceps laser, you don't want to, even that small percentage of things going bad, you want to be prepared for everything, honestly. So I just tell them, you don't want to feel it. It's not worth it, and most times it goes smooth. You don't have to worry about it. But for that one out of whatever time, you want to be prepared for all that. So.
Right. Yeah. I mean, the other thing is that hemodynamic monitoring for the complex removal. If there is a tear in the IVC, just having somebody who can handle that immediately while you're, trying to get a balloon ready and so forth, I think is a huge help too. But it sounds like maybe for just the straightforward ones, you just do moderate sedation.
Yeah. If it's a straightforward retrieval, moderate sedation, and I tell them it'll be same day procedure, in and out, and no issues.
Yeah. Okay, fantastic. So, and are you typically doing jugular or femoral approach, or both?
Jugular.
Jugular.
Yeah. So simple retrievals. So it's a good question. Simple retrievals, I go jugular. I'm using usually like a standard Cook's, like a clover snare, and usually I'm able to get it out. If it's from preparing for a complex retrieval, I do prep the groin as well. So I go neck and groin just in case.
Just in case, just have it ready.
And honestly, it also comes to the type of filter, right? If it's a optes or trapeze, I'm automatically going to the groin initially. That's definitely a big, when I tell patients initially, for a complex retrieval, I prepare them regardless that we might have to go through the groin or neck. So,
yeah. I always confuse, the optes is the one with the hook, but it's directed towards the groin, towards the femur, right? So obviously you got to do it. Trapeze could be either way though, right? I guess, just because it's not a retrievable filter, right?
Correct. Yeah. I prepare that. Usually I go neck and groin, and essentially try to do loop snare or hangman basically on both sides and try to collapse it. But that cool. One I would do neck and groin for sure.
Yeah. I would love to see that. That sounds like a cool approach. So it sounds like you have a bunch of transplants that are getting these. Do you stop anticoagulation? I imagine they're all on anticoagulation. Do you have to stop that when you're doing these filter retrievals? Or what's your protocol for that?
So simple. Yeah, that's good. So that's an excellent question. So simple retrievals, I usually keep them on anticoagulation without any issue. Complex retrievals, I always tell trainees this, you think about what's the worst thing that can happen, right? And usually the two big things that you want to think about are thrombosis or bleeding, obviously IVC rupture, right, on a complex retrieval. So I usually stop anticoagulation a day or two before, and then I would, depending during the case, the only time I actually heparinize during the case, for example, is if I see clot during the venogram before or afterwards, if there's thrombosis and I got to put a balloon up or things like that. Yeah. So to answer your question, simple, keep on anticoagulation. Complex, I usually stop just to be safe.
Okay. Well, speaking of having clot in there, let's say like there is no, you have a non-con pre-procedure workup, CT, and you can't really tell. You get them in there, you do your venogram, and you see a big chunk of clot. I mean, the way I was taught and the way I probably still practice is you keep them on anticoagulation, bring them back in 3 months and see if it resolved. What's your approach to that? I know some people are just sucking it out and taking the filter out.
Yeah, it's, with these newer devices it's made it like so easy. So if I am doing a run-of-the-mill simple retrieval and I do a venogram and I see for some reason, random reason, that there's a ton of clot that I was not expecting, I would keep them in anticoagulation, bring them back, or I would say, I'm going to see you in clinic, we'll do some imaging, and if it's still there, then I'll prep you to just remove the clot on a follow-up procedure, where I'll remove the clot and take out the filter at the same time. If I'm already with general anesthesia on the table for a complex retrieval and I see more clot than usual, then I'll go to like potentially thrombectomy on the table. Yeah, like honestly, with these new devices like Flash and Pathfinder, and it's so
Just makes it
you just
easy
put it and suck it out and just there's not
be
really
done.
much issues.
Yeah, you don't have to bring them back. They're already on the table. I mean, it's true. Well, I want to get into the procedure itself. I want to start out with walk us through your basic retrieval. Like, what's your go-to retrieval device? What size sheath do you use? When I think of straightforward, it's a snare technique, and then we'll escalate from there.
So initially, if it's a straightforward retrieval, I'm usually going to a Cook, the Clover set. That's my go-to. Usually, you can get those out within 6 months, and the filter's right in the middle of the IVC. So initially, what I do is I do some spot films, 3 spot images in obliquities, just to make sure the filter's intact, to make sure it's not tilted, things like that when the patient gets in the room. Because even within 6 months that you're not expecting it, like that can obviously, there's like, it can happen, it could tilt. And as long as it's straightforward, I just go to the Cook Clover set and I just remove, honestly.
What do you guys usually, do you guys usually place a Cook, or what's your go-to for placements?
Argon. The optional leads.
Yeah.
Optional leads. That's our go-to. And I'll tell you why. The reason for me is the fact that it's like such a small sheath. It's a 6 French sheath and it's over the wire, and like you have like control over that. It's funny, in my prior institution, we used to have to put these like PIC filters and I actually went through the basilic and just put a 6 French through and then just leave a PIC on the way out. It was for like a certain group of patients, but ever since that, I just thought it was easy. It was a 6 French hole and you don't have to worry about it. The other filters are excellent. It's just a larger hole, honestly, that's the bottom line. So that's replacement. For retrieval, simple retrievals, usually it's a Clover snare that I just try to take out. Now, what happens, sometimes is, you think you're about to go into a simple case, and obviously, it's like for some reason it tilted and it scarred within that 6 months, which happens, obviously. And you kind of, I always think about the patient. The patient's on the table, and I always gauge from the patient. It's like real time and like analyzing, like, is this patient gonna be able to handle a larger sheath, or is this patient gonna freak out if I put a bigger sheath in? Honestly, that's, and if I have to like go to hangman or, we'll talk about it like forceps, I have to go to like a 14, 16 French sheath. And if I think I should just, my gut's telling me I just got to bring this patient back, it's not gonna be like, they're not gonna tolerate. Sometimes I would say 50% of the time I'm like, this patient's handling it, like they're not flinching, they're, and I kind of have a conversation with them. Hey, I'm going to go, this is going to happen. I'm going to give you a little, and they're like, go for it,
Yeah, because they want it out.
Try to go for it. Yeah. And they want it out. They don't want to come back. And, I've had situations where I've converted to forceps, right? For like in a patient that was a below 6 month placement, and patient did completely fine, But then if they're already like with the standard retrieval kit already moving around in pain, then I kind of say, I'm just going to bring you back with anesthesia, just take this out properly and go from there. So that's usually my kind of the way I think about it.
Yeah. When you do a loop, so it sounds like if, let's say it's tilted, your next strategy besides just, the thing I like about that Clover is even if it's tilted, it's like, I think of it as like a fork with spaghetti. Like, you just go down there and you kind of twist it around and it just catches, Yeah. And that's why I like, that's my go-to as well, when it's available, depending on the hospital. But sometimes you're right. It's even after 4 or 5, 6 months, it's been already embedded and you got to do something. And walk through your typical loop snare. It sounds like that's the next place you go is a loop snare.
It's interesting, actually. I'm about like mid-career, I would say. I think earlier in my career, I went from snare to hangman to forceps, and like slowly, as you progress with forceps and your technique gets better with forceps, I've kind of skipped I don't want to admit it, but I've skipped the loop snare. I just go to the forceps because I know I'm just so comfortable at this point that I know how to handle it. I just go straight to it. I don't like to tell trainees that, because trainees, you need to be proficient in all techniques, just, be prepared for all situations, right? So what I do usually is, if I think I can get it with a hangman, I'll go this Argon came out with this Kodiak sheath, which is awesome. And the sheath itself is great. It's like a 16 French sheath with a 14 French inner. And the reason why I love it, actually, it's a really stupid thing. It's a small adapter they have to it where you can, like, it's like 2 channels you could put within the sheath, which are like 6 French sizes. So you can actually, that makes the whole loop stayer technique so much. I actually have been going back to the hangman technique just because of this Y adapter, because you're now putting in, like, you're funneling, you know how like you're always like struggling putting in 2 things through one large sheath. Now you just put it through 2 separate, like through this adapter, and you could easily just stare it out one side, pull it out, and you got your hangman set. So I usually go put down with the sauce on one side, get the sauce around the filter, try to make sure you hook it at the top of the cone, basically, and then you put your, I usually do an exchange length glide wire, then I do a gooseneck snare, get the glide wire, pull it out, and just that's your, hangman to like really give you that force to pull it out. If I can't get the sauce around where I need it right at the top of the, like right underneath the hook at the top of that, like that cone, then I'll move towards, or if I'm struggling, right, if it's like flipping or, what have you, or I can't get the sheath to go over the hook or something like that, and I can't get a good grip, then I'll move towards forceps.
Yeah. I don't know if you saw the live Sinai case that they did a couple of months ago, but they did a loop snare. For people who aren't aware, loop snare and hangmans are basically the same thing, right? Yeah, as far as I could tell. And so they were doing the loop snare, and they were like in the middle of the filter because the whole thing had embedded, and they basically just bent it in the middle as they tried to pull it up, and then they had to go to filter. So that can happen. Like you said, it's really important to get as close to the apex as possible.
Exactly.
Right.
Yeah.
Otherwise you're just going to it's
going to bend.
It's going to bend. Yeah. Exactly. And then it's a bigger mess. But, the other thing is I've personally also had the wire get stuck in the filter too, which can be problematic. And that's why it's important to use a glide and not like a Benson or something like that, or a
100%,
Rosen or something like that.
Can just 100%. Yeah, exactly. It's a great point. So forceps, when I go to forceps, I love forceps, honestly. I've gotten so like adept to it that, again, it's like those things that you don't want to, we have a large training program, but you don't want to show how quickly I go to forceps, because bad things can happen if you're not.
Absolutely. If you don't know what you're doing.
Right?
It's tactile. It's purely tactile, right?
Yeah, 100%. It's like how you feel, and it's a lot of, it's an art to it for sure. So, but we have these endobronchial force, and again, it's funny. I was at Staten Island, it's a smaller place, but they didn't have forceps initially, and I remember I still remember, I had a good relationship with the thoracic surgeon, and I just went up to the OR and was like, hey, can I see your bronchial endobronchial set? He opened it up. I'm like, I'll take that. He's like, what are you going to use that for? I'm like, I got to take this filter out downstairs right now. So like all hospitals have it. So everyone gets worried like how to order and things like that. But you just have to like go to your OR and go to thoracic surgery and get it from their set. And then, here at Columbia, obviously they had them, and we do it. We get it through this distributor where it's these endobronchial these large endobronchial forceps. Some people do use like these smaller like GI forceps, right?
Like the ones for biliary biopsies.
Exactly. Yeah. So, some people use those. I just go straight to the endobronchial ones.
They're more robust.
And I could curve. So most important thing that trainees and young physicians should understand, you can just like your tips needles, you can curve that needle. That's like there's an art to that, right? Like how good of a curve you need. You need to curve your endobronchial forceps, especially you're using them usually for like those tilted scarred in filters. So,
right.
So curve the forceps, and usually my go-to sheath, it's usually a Cook sheath that's like 16 or 18 French by 45 centimeter if I'm going from the neck. Again, I don't like to advertise an ode to Sinai because I learned it from their techniques is the inversion technique for options, right?
Yeah.
I've talked to friends around the country and they're like, that's scary. I would not do that. But it is, well, knock on wood, it's a really good technique to have in your back pocket if you're struggling from the neck. So
yeah,
I have definitely gone to the groin and inverted filters doing that. And so it's just a technique to be aware of for sure.
Because it's all one piece, right? It's all one piece of nitinol, so you could get away with that. Yeah,
exactly, for the optional leads. And that's a super important point, because if it's a G2 or, those can break up pretty
apart.
quick.
Yeah.
And a lot of them are already broken up when you see them, but it's usually for option elites where they're just cut one laser cut that you could just invert it. It comes down. It's pretty smooth how it comes, like flips essentially.
So you mentioned earlier the Kodiak sheath, but that's a 16 French. That's for like loop snare and stuff like that. But do they have a bigger size for?
It's 16, but you can the endobronchial forceps I use, I can get it. So that's why I like the sheath so much, is because I don't have to switch out the sheath to my forceps that I use. I can get through the 6.2 or 16. So if I convert to forceps, I don't have to switch out the sheath, which is great for that. So and it's a really stiff sheath. They've designed it like they had interventional radiologists look into what they want for a sheath, and they designed it for that. So they don't have to switch out sheets. They have this adapter and all that. So it makes it just all in one stop shop to use all these different techniques for. So.
And do they have do they have forceps as well, Argon?
I don't believe so.
No. Okay.
So yeah,
You're just taking them from endobronchial ones.
We actually now order them directly. There's a distributor that we have that we work with that basically we purchase them from. And usually, so the important thing about forceps to know is that lengthwise, it's just. I think it's about like 50 centimeters. And the reason I know that is because I'm also, and we'll talk about laser, but I like using laser if I can use laser. But the forceps I have, which is kind of annoying, is that it doesn't go through the cava clear, the Phillips cava clear sheath, the laser sheath, which is 50 centimeters. So that's why I just know the length, because I've always had problems with getting it through that sheath. So if I need to convert, so we'll talk, we could talk about that.
Before we get into laser, I guess laser is if you can't get it with your forceps, is what it sounds like. Or you're grabbing onto it with your forceps and then you're going over with the laser. I guess, talk me to how you do that.
No, that's a good point. What laser, ideally, the best situation is you can't get it with, you're grabbing onto it with forceps and you get the laser over. And it's just the tools that I have for, our forceps can't go through the laser. So I can only use laser in situations where I know it's going to be a complex retrieval. It's been in for a while and I could do a hangman, or I grab it with a snare and it's just, there's a ton of tissue at the legs, right? In those situations, you don't have to, what happens is you're pulling really hard and it's almost like your IVC is like inverting, like as you're pulling at the legs. But in those situations, if I know it's like there's a lot of scar tissue going to be down there, or I've been told that people have tried taking it out, they can't take it out at another institution, but I know or have a feeling I can grab the hook, then I'll go to laser as long as I get the hook and without forceps, and then I'll use the laser. Because once you use laser, honestly, it's great. It comes out really fast. It's like within a couple of minutes. So, but the problem for me is, and maybe someone smarter has figured it out, or you can use, as I said, those smaller GI forceps, graspers, because those definitely go through the laser because they're really long. So that's where I think people have gotten around that issue. But for me, I like forceps, and if I can get out with forceps, I just take it out usually.
Yeah, those GI ones are a little bit dinky. I know what you mean, because like trying to get biopsies with them. And so it seems like the purpose they would serve is not to be able to pull it off the wall, but just to stabilize it while the laser goes over it, is what I imagine. I've never done it.
The dream scenario is if I can use the forceps that I use and get a laser. I can't get it out, and I'm like really pulling at it. It's like my sheath is like buckling, at the end and everything. If I could just put a laser like right over that, and I'm sure it's going to happen. Maybe someone's doing it. I'm sure someone's doing it, but I'm saying that's the issue I'm having right now, essentially. So,
what are some of the pitfalls of laser? The thing I would be afraid of is like that laser. Just if you're at an angle because you're pulling everything, is you're going to laser right through the wall, IVC wall.
Yeah, that's the worry. You got to make sure things are lined up and going straight down. Yeah, you're going millimeters at a time with the laser. Like I like it. I'm very careful when I'm like tracking. Like I go laser, then I use the outer dissector sheath, laser, outer dissection, do it in a stepwise fashion. Honestly, it comes out pretty quick. It's faster than you think, but you're still going treading very carefully, because Worst case scenario, as you said, is you're at an angle and it pops through the wall on your host, basically.
And what is the biggest sheath size you've ever had to use? I mean, what, kind of talk us through your escalation with sheath sizes.
Yeah, it's really good. So I usually go 16 or 18, 45, 16 French, 45 centimeter initially if I'm going from the neck. If I know things are getting hairy, like things are bending, like you mentioned earlier, like the filter folded on itself, or things have broken up, and that has happened for sure, then I go up to 20, 22 or 24 French. I've actually moved towards, and again, this is from, give credit to Sinai, it's a Medtronic Centrant stent graft sheath. It's a really stiff, like metal sheath that initially, we were using it for just when we inverted filters, the optional leads, but now that's my go-to sheath when I'm going like above and below, things have gotten hairy or complicated. I put in this sheath, and that's just to protect you if things fold up or legs are broken up, or I have a bunch of different, I got forceps on one side or loop snare on the other, or two forceps sometimes, one from above, one from below. If it's like a trapeze or an optese that I'm having trouble taking out, so I go up to a 24 French
In the groin.
In the groin, and also potentially the neck if I have to, depending on where what's happening. So
yeah, okay. And for these complex ones where you're dual access, I mean, I know you have trainees, but it's a complex filter retrieval. Do you pull in colleagues, fellow attendings to kind of give you an extra pair of hands?
Yeah, every once in a while. Honestly, it depends. Also, most of the time trainees are pretty good, and I can like literally say stop, go, green light, like I'm do my kids, like green light, red light, stop, but usually trainees definitely, when it gets hairy and I need help, like a real, like forceps from one side, forceps from the other, or laser, things are getting hairy. That's why I love being in a place like this, is that there's people like all around you all the time. Usually there's an audience outside, like like looking at this stuff, like what's happening, like, you know what I mean? But it's easy to get people around. So
yeah, that's good. Now I've talked on prior episodes of times when I've been by myself when I wish I had an extra pair of hands, and that's the difference with community stuff. And I've had cases where they're complex, and I had to reschedule and call up and say, hey, I got to have two hands on deck here. There's no way.
That's a great point. I've done that before, for sure.
Yeah,
I said,
makes you peace of
especially
mind,
in my prior institution. Yeah, if I needed to, things get hairy. I think it's a very important, and again, that's another art of just experience that is that to build that signal inside you that says, hey man, I got to stop. Like this is not gonna, we just got to reschedule. That's the best thing. I know it's like a nuisance. You got to like redo, get anesthesia, so whatever it is, or the patient's come back. But if it's safest for the patient, that's the most important thing,
Yeah, absolutely. Because, the patient's upset, their family's upset, they got to take a day off
work through all that.
I mean, you got to work through all that. Yeah. But you're right. I mean, it's way better than trying to explain a complication or sending them to, the OR. So I completely agree with that. Any other pitfalls to avoid as we, think about like where things can go wrong, especially with forceps?
First, it's important to prepare for anything that's going to go wrong, right? Like the things, as I said earlier, you're worried about bleeding or thrombosis, and having whatever your favorite balloon is. Like for me, it's basically an Atlas 20 millimeter balloon, or some people I know use like the aortic balloons, the Reliance, things like that. It's important to have your largest favorite balloon in the room that you know how to put up. Back before Philips was cava clear, there was Spectranetics, and they actually had the balloons that were, we had also that we used. It doesn't matter the name, or it just has to be a high pressure, large balloon that you got to put up there, at least 20 millimeters, right? So that's really, if there's obviously, but in both situations, honestly, if there's bleeding or thrombosis, you want to just get thrombosis, you anticoagulate, put up a balloon right away. If it's bleeding, just put up a balloon. Put tamponade for about 5 minutes, and then so those are the type. And also have a stent graft available. I've rarely, if ever, had to. Probably I've done it. I know 2 situations that I've had to do that in, but just being prepared that could happen is so important. Another thing is to make sure I have wire access across the site. If things are really getting hairy, I don't have wire access all the time, but if I know things are getting hairy, if there's like chronic thrombosis or something like that, I'll make sure to have wire access while I'm doing this, just because you don't want to be in a situation where you're like trying to poke through and try to get a wire to regain access across whatever situation you're in. So those are the main things, honestly. And it's a, the whole, back to your anticoagulation, it's an interesting thing because you want to give anticoagulation, not have occlusion, but then they can have massive bleeding. There's like it's literally, devils on both sides essentially. So, but those are the main things. And, just simple things when you're using a forceps is make sure, what happens a lot is, especially when you're younger, you're just in the zone of trying to get this hook. And now you're like, got this forceps that it's like going array, like you're just poking that thing, like it's going forward. You're like, with it open, and you don't want it to poke through and get onto the other side like the aorta or something like that. So just being calm, being aware, making sure you're just very controlled technique is really important. So I think that just comes with experience, honestly. So
post-procedure. So let's say you get the filter out. I know there's something that we all do, but trainees might not be aware of, like what's the most important thing when you get that filter out and you put it on the BackTable?
So I take a picture. I'm just kidding.
Yeah. Put it on Twitter immediately.
I put it on Twitter. Yeah, exactly. Yeah. No, we get this question a lot, like from patients also, can I see the filter? Can I take the filter home? And obviously where you work, there's legalities to that, so honestly, I just send them all to pathology, and they can actually get them from pathology at most places.
Right.
So,
you can't just hand it to them anymore.
Yeah. Sometimes if they're awake and they're like, I just like show it to them, you know what I mean? Here's what it was at. But, take the filter out, depending on how complex they are. Most patients I send home, if it was a late case in the day, I may admit them overnight just for observation. Those are just things to think about. But usually I send them home. They're in recovery for like an hour to two, depending on the complexity of the case, 4 hours max if I saw bleeding, and I want to really be sure make sure before sending them home. And then, restart anticoagulation the next day as long as everything's okay. And I usually, honestly, I make sure to see them in clinic. If it was a real complex case, definitely see them in clinic 2 to 4 weeks after, because things like rethrombosis, you got to make sure, and, just random things that could have happened in those weeks. You just want to make sure that they could still have bad abdominal pain, or just you might have to rescan if that happens. But you should definitely see them in clinic if it's a complex filter retrieval within a month for sure.
Yeah. And then going back to what you were saying about how all filters aren't made equally, definitely count those struts. And then take an X-ray of the chest.
Sorry. Thanks for reminding me. That is 100%. I always take a chest X-ray of the chest, because exactly, you put it on the table, you count the legs, make sure that nothing's broken off. I have had to do cone beam CTs run on the table. So if I see a leg, for example, that's still in the IVC, I want to make sure that's not free floating, right? I want to make sure that it's like embedded into the retroperitoneum or wherever, that it's not going to move, or it's in the wall or something like that. So I've done a cone beam CT just to confirm that. So that's very important. Thank God I haven't had a leg. I've had to take out a leg from the pulmonary artery branches, but luckily it wasn't from me having sending it up there. But you have to check, especially medical legal purposes. I think it's so important.
Yeah. Okay. Well, I know you brought some cases. Let's see if we can screen share and take a look at them.
Yeah, for sure. So this is what I was referring to when I was talking earlier, is the cheat sheet that we use for all the different types of filters. And then we actually have a little kind of protocol, kind of cheat sheet guide that all our trainees use that I was referring to. But there's images of all the filters that we generally see in consults. So the first case is a 58-year-old female, history of subarachnoid bleed, filter placed in 2013, presents with chronic DVT. She had swelling in one of the extremities. Basically, this is an evaluation for removal. I think this was referred from one of our colleagues in cardiology, because just given the type of filter, which I'll show you in a second. We did have a pre-op CT, which I didn't show, that showed it was actually a greenfield filter, which was a little questionable because it was placed in 2013. I'm not sure we should be placing greenfield, or they were being placed
Yeah.
in 2013. So that was just maybe the timing was off a little bit. But so when we see a filter like this, again, it's a greenfield filter. It's obviously going to be tilted. I do the 3 projections, which is the AP and the 2 obliquities. This is one of the obliquities here. And this type of filter, I know we're not going to be able to use kind of our simple technique. Actually, as I said earlier, I know it's scarred in. I'm going straight to forceps. So I get my large sheath in place, 18 French by 45 centimeter from the neck, and I go straight to forceps. As I said, we have a curved forceps that's going right afterwards. So again, just very fine movements. And it's an important technique point that you want to unsheath your forceps. You don't want to just send your forceps out just to make sure you don't perforate or things like that. But once you get it to the level of where the top of the hook is, that's where you want to keep it, and that's where you're starting to maneuver it. The whole goal, obviously, is to maneuver it so we can get onto the top of the filter right there. And then and as I said, this is really a tactile feel. Like once I'm feeling where that filter is, once you grab onto that hook, that's where you're sheathing that filter.
Yeah.
In this case, it kind of went really fast at that point. But in this case, a lot of the force, and there's actually really good articles that Will Coe and the Stanford group put out actually demonstrating the amount of force it takes to really sheath that filter, especially at this point where you see these hooks at the bottom of the filter. So you're just pulling at this point really hard and hoping it comes in. And in this case, it came pretty smooth. So this is a straightforward forceps case.
Yeah, one of my program director at Vanderbilt said it's kind of like, the force of starting a lawnmower, basically. Like you're yanking at that point, and don't be afraid to, because that's what it requires. And he's right. He's right.
Yeah. And I think you alluded to it earlier. You want to make sure that the angle is straight and you have a good straight thing, because you don't want to obviously push at an angle that potentially could just pop through the side, which people have done. So it happens. So.
Key thing is pull, not push, right?
Exactly.
Exactly.
Exactly. This is that companion. This is what I was talking about, the inversion. Again, I don't like to advertise it, but I love it because it's so, it sounds worrisome, but for example, a filter is tilted, either it's tilted to the right or left. That allows you to determine which way to put your sheath up, from the left groin to the right groin, because you literally can put your sheath. This is that Medtronic sheath I was talking about. It's a really nice sheath. It's a stent graft sheath, and you literally put it right into the cone of the filter, like to the bottom, the top, the apex of the filter, and then you unsheath your forceps. You grab the top of the filter, and it literally flips right into it. It's usually pretty quick that it flips into one piece. So that's nice. So
incredible.
Yeah, that's the post though. Next case is...
How did you decide on that, like jumping to that? Had you already tried from above?
Yeah, usually I've tried from above, and for some reason or another, even despite curving the forceps, for some reason it's just requiring a lot of time, and I see it so tilted to the point that, I can get a sheath right into the apex of it and it'll come right out. You know what I mean? Just based on what it looks. So that's when I usually switch to it, to switch to this. This was a lady, actually, she had 2 filters, 50-year-old, history of lupus, multiple thromboembolic events, 2 filters placed, 2011, 2014. One of them was a select. Again, this is a spot image. Select at the top, and then you have your trapeze at the bottom. You don't see a hook here. She was chronically occluded. This is from the right. This is from the left. So in these cases, you want to make sure you get wire access across whenever you're doing your work. You're prepared to, in this case, I have a sheath from above and below. Initial plan is potentially, things I think about is, okay, am I going to go straight to forceps? Am I going to try to grab up here with like a hangman, grab from here from a hangman? You can see the orientation of where this was. Mm-hmm. Obviously it's a little, I think I tried it to do a hangman. It was just getting to be difficult. And then I switched to forceps. This was a run before. So in this case, actually, I ended up going straight to forceps. And the thing about these trapeze filters is, if they've been in for a while, if they don't have chronic clot in them, they can break up pretty easily. So in this case, it ended up breaking up. She was chronically occluded afterwards, which ended up ballooning and then stenting across. And you could see the post flow that occurred here that she had. So
it looked like a tulip or something from the top one. top
Yeah,
filter? That just came out easily, or?
Yeah, that came out. I used forceps from the top as well. Again, I'm just highlighting my love for forceps here, unfortunately.
Yeah.
So that just came out pretty quick.
That's great.
Afterwards, so
a great result.
And then the last, those were the two filters again. I can't. This broke up in a bunch of pieces. This is just quickly show. This is a laser case, and this was a patient that we actually was referred for adrenal vein sampling. And obviously the filter was in the way to do the adrenal vein sampling. So we wanted to take the filter out before. She actually had an attempted removal at an outside hospital before. So before we didn't have any imaging, we go through the imaging, there's a contrast imaging. There's no clot within the filter. But this was, I believe, a select filter that we knew from this CT that the hook was in the middle of the IVC. So this is what I was talking about earlier. I know that I could potentially go straight to laser in this case, knowing that someone had a difficult time before. You see the struts extending outside the IVC, right?
Yeah.
So you know that this is probably going to be a difficult case that, potentially I'm just going to go straight to. Obviously, I'm going to try with a snare, see how hard it is to take out. So I was able to grasp it with a snare. I actually want to credit one of my colleagues. I did this with one of my colleagues. It was his patient that we did it together. So grasped it with the snare, as you see here. And then this is the laser sheath right here that's grabbed. Let me pause it here. So this is the laser sheath right here.
Okay.
And you're kind of, as I said, you're slowly tracking the laser down with your outer dissector sheath in a stepwise fashion. And usually when you first pull on the snare, pull on the filter with your snare, get to the point where you feel resistance, and that's where you start with the laser. Here, again, this came out super quick. It was within, I think, a minute. Once you get the laser going, and then you pull it with your tension, it just pops right out. So it's nice. So
yeah, it almost looked like it broke through at the middle of the filter, and then the actual hooks came out pretty easily, which...
Correct. Yeah.
Do you find that's usually the case? Or?
Yeah. No, that's a great point. Usually the tissue is down here where
the hooks
are embedded. Yeah. But in this case, I mean, it can be anywhere where the tissue forms. In this case, I think all the tissue was basically at this point right here. So, and then the last case, this was a case where it was a Optes filter that had broken struts within it. And when I think about this, again, I'm thinking if I can get a hangman or a snare around these two sides, then I could then use laser and or forceps in that situation, either forceps from the top to grasp and laser from the other side. And that's essentially what we did. We actually were able to get out with the hangman technique with sauce around it. And this was, you don't see it here in this picture at bottom here. This was actually the laser sheath, and this was the outer dissector. But we were able to get this out by using laser and then dissector all from one access. So we didn't actually have to grab it from the top, essentially. So,
wow.
So that's this here. So again, you want to be prepared for everything, but you can. Things will obviously change up in the middle of the case, whether it's you only have to use one side, whether it's the groin or the neck, or you have to use both sides or what have you. So
Have you had to do like bilateral groin and neck, just sort of like three, because that very complex one where you ended up stenting, that looked like almost, it was like the trapeze was even angled towards the left iliac.
Yeah.
But you were still able to pull it from the right iliac, which was pretty incredible.
Exactly. Yeah. In that case, I think it was just so I have access with my wire through that, just in case things got hairy and there's a bleed and, just to make sure that you maintain access in that chronic occlusive state, basically. So,
got it. Well, Noor, thank you so much for coming on the show and sharing your expertise, and thank you for sharing these cases. I'm looking forward to hanging out next week.
All right. Thanks, Aaron. I appreciate it. It was great.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon.
with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.